Greetings, and thank you to everyone joining us live or watching this recording. My name is Ann Lloyd, and I'm the Antimicrobial Stewardship Program Manager at Sanford Guide. We're excited to host this webinar in honor of World Antimicrobial Awareness Week and to provide you with strategies for focusing your antimicrobial stewardship resources. We know that human and financial resources are variable across countries, regions, and care settings. So we aim to provide ideas for starting or enhancing existing antimicrobial stewardship programs that don't require a large investment of those resources. We hope these suggestions will be relevant to all patient care settings and in any location. The objectives for today are listed here for you and include a few underlying assumptions. We presume most of you are already somewhat familiar with the concept of antimicrobial stewardship. If not, we encourage you to view our past webinars on our YouTube channel or visit the educational resources section of our website to learn more. Many antimicrobial stewardship recommendations and best practices have originated in high resource settings and in particular academic medical centers in the United States. What is lacking are practical strategies that can be implemented regardless of resources, and that's what we hope to share with you today. Our roadmap for today is that we're going to talk about how to take action to address AMR and why we need to do so. Briefly spend a few moments thinking about the barriers to our successes, and then walk through three things. Number one, build and educate your team, develop guidelines, and finally shake on it. And then again, we'll have time for questions and answers at the end. So first of all, why do we need to take action? What's the importance of this, and why do we really need to get involved at our local facilities? So on September 26, 2024, the United Nations held a high-level meeting on antimicrobial resistance. And out of that meeting resulted in a political declaration, including the goals you see here on your screen that are related to antimicrobial resistance. As stewards, we can take guidance from these goals to inform our local efforts. And so in brief, those goals that are by 2030, global deaths associated with antimicrobial resistance will be reduced by 10%. That 70% of antibiotics used for humans belong to the WHO access group of antibiotics. That 100% of countries have basic water, sanitation, hygiene, and waste management services in all of their healthcare facilities. And finally, that all countries report surveillance data on antibiotic use and antimicrobial resistance. Specifically looking at that goal, that 70% of antibiotics used for humans belong to the WHO access group of antibiotics. I wanted to provide a brief overview of what that means. The WHO Aware Antibiotic Book was developed to provide actionable guidance for empiric antibiotic use, and it provides recommendations for antibiotic choice for more than 30 common infections for both children and adults. Classifies antibiotics into these three groups: access, watch, and reserve, based on the potential to induce and propagate resistance. It identifies antibiotics that are priorities for monitoring and surveillance, and has overall goals of reminding us that antibiotics are not always needed. For viral infections, of course, we don't need antibiotics, and we can use a watch and wait strategy. That we're really trying to, again, increase that access use to that United Nations target of 70% of our antibiotic use. We want to reduce the use of inappropriateness of the watch category and really reduce the use of that reserve group. It should really be used in last resort life-threatening infections. Just one caveat, not all agents are included in these groupings. So keep that in mind. And if you're interested in learning more, the links on this slide will take you to more information about these different groups so that you can see all of the antibiotics in which categories that they fall. So how has antibiotic use contributed to antimicrobial resistance? From a study published last year in The Lancet, we know that antimicrobial resistance is projected to cause 10 million infections annually by 2050. Many studies have demonstrated that inappropriate antibiotic consumption is a large driver of resistance. This study that was published just this month in Lancet Global Health looked at a database for tracking pharmaceutical sales across 74 countries. And what they found was in comparing antibiotic use between 2010 and that consumption increased in certain regions of the world in Southeast Asia, Africa, the Americas, and Eastern Mediterranean regions. And in those countries, 4 of 5 countries in Southeast Asia, 3 out of 5 in Africa, 7 out of 13 in the Americas, and 5 out of 9 in Eastern Mediterranean. It decreased in the European region and the Western Pacific region. The use of less than 60% of access antibiotics. So remember, the target is now that we want 70% of access use, but in the study, they looked at 60%. So there were 9 countries in 2010 that used less than 60%, 9 countries again in 2021. The major difference there was in the countries that were included. So those countries changed between 2010 and 2021, but we didn't really make any progress in increasing that use of access. Antibiotic use, looking at that specifically, the highest used agent was amoxicillin, which is not necessarily a bad thing. That's one of our access antibiotics. However, carbapenem use increased by 54% from 2010 to 2021. And this really shows us those disparities in antibiotic use across our regions of the world. They also looked at antimicrobial resistance. However, they were only able to look at European data for that. But what they did find was that antibiotic consumption was associated with antibiotic resistance. Looking more specifically at resistance, the World Health Organization's Global Antimicrobial Resistance and Use Surveillance System was launched in 2015 to monitor antimicrobial resistance and was expanded in 2020 to look at antibiotic use. This includes over 23 million infections from 104 different countries. And you can see here some of the key findings from the report in 2025, that 1 out of 6 of laboratory confirmed infections were caused by antibiotic resistance organisms. Resistance was more common in certain regions, similar to the previous study that we just talked about. Those regions were Southeast Asia and the Eastern Mediterranean regions, followed by Africa, and less frequent in Europe and Western Pacific regions. Most concerning out of this report was the increase in gram-negative resistance, particularly for carbapenem's Acinetobacter species, and that antimicrobial resistance was most problematic in countries with weaker health systems. So now that we've set the stage for why it's important for us as stewards to really act now, let's talk about some of the potential barriers that we might encounter while trying to improve antibiotic use. There are a lot of factors involved in improving antibiotic use, but antimicrobial stewardship, or AMS, has been central to this fight for more than 20 years as a formalized tool for tracking and improving antibiotic use. There are a lot of components that go into antimicrobial stewardship listed here for you, and they're all central to the success of antimicrobial stewardship programs. However, they can also be barriers or challenges to improving antibiotic use. Thinking particularly about personnel or human factors, we can have a lack of support in our healthcare systems for having personnel involved in antimicrobial stewardship. We have a lack of training. There's hierarchies in our hospitals and health systems that can be barriers to improving antibiotic use. There are also other human factors, such as in certain places around the world, antibiotics are available without a prescription. And so that can hinder our efforts at improving antibiotic use when patients can get antibiotics without interacting with their prescriber. There's also human fears of underprescribing, which might lead to poor patient outcomes, as well as just other competing priorities for our human resources. Looking at technology, we know that technology varies across our healthcare systems. We have variation in our medical record formats. Some of us still use paper charts, while others of us have very high-functioning electronic medical records. Some of us have wide range of diagnostics available to us, while others may have no diagnostics or limited diagnostics. Similarly, decision support tools to help us in our antimicrobial stewardship efforts may be non-existent at some of our facilities. If you're in an outpatient setting, you may have incomplete access to patient data. You don't have access to the patient's medical record to find out what their cultures were or what their previous antibiotic use might look like. And then we may just have gaps in our data on antibiotic use and resistance if we're not tracking, and we don't have an electronic medical record to track those findings. And finally, the other challenge to focus on is our funding challenges. So financial resources vary across our settings and across countries. As I've already told you, there's a higher burden of antimicrobial resistance in our low and middle income countries. Oftentimes, this may be because of a lack of a regulatory requirement for antimicrobial stewardship or for improving antibiotic use. We also know that there have been interruptions in external funding resources. And if there's no internal funding, then that can be a challenge for us as well. And lastly, we may have limited access to antibiotics in certain settings. So one of the World Health Organization reports that was published earlier this year noted that in some countries, there was no use of reserve antibiotics, which while that might seem like it's a good thing, because we're trying to avoid that use, it may mean that there's no access to those reserve antibiotics in those countries where there's high levels of antimicrobial resistance. As mentioned, this lack of equitable access to antibiotics across the world is compounded by our antibiotic pipeline. So this World Health Organization report from 2025 about the global antibiotic pipeline just tells us that there are not as many new agents coming into the pipeline. So from 2023 to 2025, that decreased by 7 agents. Only 15 of the 90 agents currently in the pipeline qualify as innovative, meaning that they're different compared to what's already on the market. 10 of these 90 agents confirming that they have cross-resistance with other agents in their same category. Only 5 of them are effective against one critical bacteria, and an example of a critical bacteria is our carbapenem-resistant Enterobacterales. We would hope to see more agents effective against these multi-drug resistant pathogens. And most concerning, there are gaps in agents used for pediatric patients, oral agents, and solutions for our resistant pathogens. So how can we overcome these barriers locally at our own facilities? First of all, we need to tailor to our specific needs and our capacities of our facilities or our healthcare settings. We really need to utilize the local expertise and form a multidisciplinary team. We provide regular training about antimicrobial resistance and inappropriate antibiotic use. We need to develop empiric guidelines and use our audit and feedback strategies. And we need to try to gather data, whether that's electronic, if we have access to that, or using paper-based methods to really identify our opportunities. And we need to keep a really narrow focus, particularly in the first year, in order to set ourselves up for success. Really trying to limit yourself to no more than 3 activities during the first year of developing or revising your program to really set yourself up for success. So the first step, as mentioned, to overcome these barriers is to build or strengthen your team. If you already have an existing team, think about strengthening your team and provide education to them. So in terms of building the team, really need to formalize this team through support from your facility. And if that's something that's lacking for you, are there national or regional regulatory requirements that you can rely on for support that you can take to the leadership at your facility to really emphasize the need for antimicrobial stewardship? You need to appoint a leader or co-leaders. Historically, a physician leader or pharmacist leader have been the most widely used. But if you're in a setting where you don't have access to those individuals, you might have a microbiologist or a nurse or even a community health worker be the lead in your facility. Again, forming that multidisciplinary team, I've listed here on the slide who might be involved in your team. Some of the most successful stewardship programs have involved providers who are out there taking care of patients, who understand the challenges to taking care of patients in your settings. So make sure you're getting those people involved in your team as well. Write a charter to formalize your team. And if nothing else, explore collaboration locally or regionally. Can you group up with other facilities in your region to strengthen your efforts by working together and sharing resources? Characteristics that you're looking for in your team. Obviously, we need clinical knowledge and clinical skills related to infectious diseases, but also important is implementation expertise, because implementing these strategies is so important to the success of these programs. We need to be able to communicate and have leaders on our teams. And most importantly, our team needs to be able to deliver consistent recommendations, to have one voice about improving antibiotic use at our facility. A paper published earlier this year by Estimated Study Group for Antimicrobial Stewardship identified 88 competencies for antimicrobial stewardship teams. These competencies are organized into 15 different domains and have been found to be essential for antimicrobial stewardship teams. And so as you can see, there's no one person who is going to have all of these skills. That's really emphasizing this need for this multidisciplinary approach to make sure that you have someone on your team to meet all of these different domains and competencies. And if you don't have access to that, explore education and training to gain those skills and competencies. Adapt existing training program to meet your needs. There are a lot of training programs available, some of which are free and can be used and adapted for your needs. Another suggestion is to seek experts at other facilities. Can you go shadow an existing program at a facility, at the hospital in the next town over? Truly trying to identify what's been successful for others in your region to mirror that success at your facility. As mentioned here, some training resources or organizations that have training resources. Some of these are freely available. Some of them require a fee. Some of them are a lower cost depending on where you're located in the world. So feel free to explore those. In one of our previous webinars, we spent some time looking at these resources. So feel free to check that out to find out more about those resources. Once you have that team, you need to identify opportunities for your work. I think most importantly is meet the people at your facility. Listen to them. What are the things that are impacting their abilities to prescribe appropriately? And invite their suggestions and then present a plan of action to them. And then use those resources wisely. Consider facility-wide strategies that have a really narrow focus so that you can make a big impact. Look at one unit or one disease state. Maybe reduce the use of a single agent or class using those World Health Organization aware categories as your strategy. And don't forget about the bedside nurse. They're there day in and day out interacting with the patients. They can be really helpful in your antimicrobial stewardship efforts. I encourage you to check out the resource cited here on this slide to learn more about how nurses can be beneficial in antimicrobial stewardship programs. So these are the key strategies that stewardship programs can think about using, and central to most efforts around antimicrobial stewardship have been audit and feedback and prior authorization and restriction. But as you can see, I've categorized those as a medium resource technique that are really time and human resource intensive. And so I'd encourage you, if resources are not as available to you, to focus on some of these lower resource opportunities, such as guidelines, having antibiotic rounds, and categorizing your antibiotic formulary based on the AWARE classification. And we're going to take a deeper look at some of these now. So first, let's develop our guidelines. Why do we need guidelines? They're really helping us standardize our prescribing practices and promoting evidence-based treatment. Key stakeholders can be involved in the development, like I mentioned before, and that's so helpful in making sure that guidelines are going to be successful for you. And then later, you can use these guidelines to assess appropriate prescribing and hold prescribers accountable. These guidelines can be educational. When you're using a guideline, you begin to understand the appropriate way to treat a certain infection. And it can really be used across all settings. Beyond the rationale, we have a lot of evidence to support guideline use. Guidelines have been shown to impact all of the things listed here on this slide, including increasing appropriate antibiotic use, decreasing adverse effects, decreasing cost. And they have done all of these things without any documented adverse effects on clinical outcomes. So hopefully this shows you, the importance of these guidelines and the ability that they have to impact our outcomes. Key features to our guidelines are that they should be evidence-based and adapt existing guidelines. And if you don't have existing local or regional guidelines, can you adapt some other kind of guideline? There are plenty of guidelines available out there, including those found in the WHO AWARE playbook that you can adapt to your needs. But really important to incorporate your local data to make sure they're easy to comprehend and to revise them routinely. On the right-hand side of the slide here are some certain sections you would want to think about including in your guidelines to make sure that they are simple and easy to use. Think about targeting specific disease states. The 4 disease states listed on this slide are some of the most common causes of infectious diseases around the world and are a great starting point for developing a guideline. If these don't speak to you or aren't relevant at your facility, then find that disease state that is most common at your facility or where you feel like prescribers are struggling the most and use that as your starting point. An example guideline here on the screen follows that format that I mentioned previously with the headers for the different sections of the guidelines. It's a single page, it's simple, it incorporates, again, all of those key features, and it has the World Health Organization aware categories with our antibiotics highlighted by the color of the category that they belong to. So again, keeping it simple makes it easy for your prescribers to use. Again, these can be used at the point of prescribing, and then while you're performing your audit and feedback activities, or while you're evaluating appropriate antibiotic use. You can evaluate adherence to these guidelines, which in turn will tell you about whether people are using antibiotics appropriately based on your guidelines at your facility. However, these guidelines cannot stand alone. Anyone who's tried to implement a guideline before knows that you can't just put the guideline out there and expect that people are going to use it. You have to have an implementation strategy. You have to educate your providers about the guideline and the importance of using these guidelines. You may want to consider incentives for adhering to guidelines if that's something that's available to you at your facility. Just key to this is making sure you have that implementation and dissemination plan. How are you going to get these guidelines into the hands of your users? Are you going to use an electronic method to disseminate them? Are they going to be paper-based? And again, are you going to require that they be used to take care of patients with that particular infection? One way to enhance your guidelines is to develop a Handshake stewardship service. So let's talk about using Handshake stewardship to amplify your guidelines. Handshake stewardship is a form of prospective audit and feedback that was first described in 2016 from the Children's Hospital in Colorado. It has 3 key features. There is no restriction or pre-authorization of antibiotics in this method. There is a review of all prescribed antimicrobials at 24 and 72 hours. And in this facility's program, that was completed by a pharmacist and a physician team. That pharmacist and physician team then provided in-person feedback to teams at their facility. This resulted in a reduction in antimicrobial use by over 10%, along with a cost savings of $1 to $2 million. It allowed for education and collaboration. And later, the same group published an 8-year follow-up study demonstrating a 25% reduction over a 5-year time period. So this was a very successful strategy at this facility with a pretty minimal time commitment. The pharmacist physician team spent 1 hour each day doing the antibiotic review and then about 1 hour rounding on the 15 teams. Barnes-Jewish Hospital implemented the same strategy in adult patients admitted to medicine wards across 13 different medical units with over 200 different providers. In their study, they did 3 days per week with a pharmacist and physician team of this in-person Handshake stewardship. And they only reviewed non-ID consult patients and rounded with the primary teams. While they didn't see a decrease in antibiotic use, they did find that there was a trend towards lowering and otherwise increased use. What they saw there, the most common recommendations were discontinuation, de-escalation, and shortening and defining duration of therapy. They later published a follow-up study earlier this year where they expanded this efforts to their surgical wards. In this population, they did see a decrease in antibiotic use. What about in a setting where you aren't in an academic medical center? The study published in February of 2024 was a 75-bed oncology setting without any kind of structured antimicrobial stewardship program. They had a pharmacist review all patients with antimicrobial orders and then communicate the recommendations during rounds and sometimes on the telephone. And what they found was 94% of their recommendations were accepted. And they saw a decrease in use of special vigilance medications, so those reserve category type medications. So this demonstrates that this strategy can be used in different types of settings with different types of resources. It's also been evaluated in critical care units and in oncology units such as this one. Benefits that have been described include breaking down barriers, improving relationships. That's so important is this face-to-face interaction to really build rapport and making sure the antimicrobial stewardship team is visible, really conveying that trust and respect. And most notably, it's been demonstrated that this does not necessarily lead to fatigue from your antimicrobial stewardship providers. So we know a lot of folks have been experiencing burnout, and this strategy seems to not lead to that. However, there are some challenges. As I mentioned, it's been most well described in academic settings. So non-academic environments may have more challenges. There's not set times for rounds, for example. In addition, daily review may not be feasible, and there may be limited time for personnel to participate in these activities. So what are some modifications that you could make to overcome these barriers? You can have your antimicrobial stewardship pharmacist or your antimicrobial stewardship team train your non-antimicrobial stewardship pharmacists to grow their confidence in making these interventions while they are rounding. You might limit your focus to a specific unit or disease state. So as I mentioned, this has been well described in critical care units, and that might be a great area for implementing a program such as this. You might focus on a single agent. So if you have an overuse of meropenem at your facility, perhaps you investigate just looking at patients with meropenem and performing handshake stewardship for those patients. It's also been implemented virtually during the COVID-19 pandemic. And while that's not the same as in person, it may be an effective strategy for those of you trying to cover multiple facilities from a single location. At another facility, the recommendations from this team were agreed upon with the primary team and then incorporated into the medical record. So it's another strategy for improving this antimicrobial use and antimicrobial stewardship. And then lastly, if human resources are your biggest barrier, this has been, again, well described using non-daily strategy. So 3 times a week, for example, instead of every day. So it really can be modified based on your needs and your setting. So in summary, we have talked about the need to act now to address antimicrobial resistance during this World Antimicrobial Resistance Awareness Week. I identified barriers and some enablers to your antimicrobial stewardship strategies. And then we talked about 3 things that you can do with your limited resources to build your antimicrobial stewardship program. So first of all, building or strengthening your team, providing education for that team and really enhancing their skills. Number 2, developing, revising, and implementing and disseminating your guidelines using really simple strategies to making sure that people have access to those guidelines. And then lastly, considering handshake stewardship to increase the uptake of your antimicrobial stewardship recommendations and guidelines. We'll share a few selected tools and resources for you here on the screen while we get ready to answer your questions with the 15 minutes that we have remaining. So let's go ahead and see what questions we might have. I saw some people raising their hand earlier. If you have those questions, you can type them in to the Q&A or the chat so that we can answer those for you. While we're waiting for questions to come in, I'll just talk about some of these tools here on the screen. This first tool, an antibiotic review form, might be something that you can use to help your stewardship handshake rounds. It's something that you can use with the team to discuss on each day, each patient who's on antibiotics. It gives you a nice tool that you can use to do that. There are a lot of resources here on the Infectious Diseases Society of America, tools for antimicrobial stewardship, along with their training program. Of course, the World Health Organization has been a great supporter of antimicrobial stewardship for many years, and they have a lot of great resources on their website. One of my favorites, the Society of Infectious Diseases Pharmacists, as I am an infectious diseases pharmacist, has a great toolkit, including some patient resources that you can use to provide education to patients. And then, of course, our own references and resources available on our Sanford Guide website about antibiograms and other aspects of antimicrobial stewardship that you might want to check out. I am seeing that maybe we have some questions. Let me find those here on my screen. Do we have any example committee charters? You can find those in some of these toolkits. Really, in my experience, our committee charter identified the individuals who are going to be members of our team, talked about our goals for the antimicrobial stewardship program and how often our committee would be meeting. It's really just getting that documentation that you're a committee and that you're going to be setting out to achieve certain goals and meeting on a specific frequency. Next question is, when do you suggest a restrictive antibiotic policy? This is a great question. Antimicrobial restriction, or what I like to call is antimicrobial protection, a formulary of protected policy, is a really good strategy, again, when you don't have a lot of resources. However, a couple of caveats to that is that you do have to be able to enforce that policy. So if you have an electronic medical record and you can incorporate the restriction into your electronic medical record, that's been really successful for restriction policies. But if you don't have that type of resource, and it's going to require individuals to make a phone call or get approval before prescribing, you need to make sure that that process is available regardless of the time of day or you need to have, a way for people to get around that, because you don't want to withhold antibiotics from people who would need them while waiting for restrictions. So there's a lot of great studies out there about that type of a policy, and it's certainly an important feature of antimicrobial stewardship programs, but you need to make sure that you implement it in a way that makes sense. The question here about pre-op prophylaxis and whether that's a pharmacist role or infection prevention role. And I think really a collaboration about antibiotic pre-op prophylaxis is between infection control and pharmacy, as well as our surgeon colleagues, is the best approach to improving antibiotic use around surgical prophylaxis. And that's a great starting point, making sure that you have guidelines for antibiotic use around that perioperative period. There's a lot of great data out there now about limiting the duration of antibiotic prophylaxis. And so I'd encourage you, if you already have a surgical prophylaxis guideline, to look at your duration of therapy and see if you can make any improvements there. So we have someone who has some experience using the Handshake model, which is great. So after 5 years of using the Handshake model, they've noted this may create an over-reliance of teams on the antimicrobial stewardship team, having them wait or postponing simple discussions until the team comes around. Any ideas on how to overcome this? I think probably depends on your facility. If you're dealing with learners in an academic model, then every month you're having new learners. And so I could see how those new learners would not have that confidence to make those decisions and would be waiting for you. But if you're working with established teams and you've been working with these same people over time, I think really empowering them by letting them know, we've talked about this before. This is one that, with confidence, you can be sure that the duration of therapy is this many days for this infection, for this patient type every single time. So I think education is part of Handshake stewardship, providing micro learnings or in-service presentations, just really empowering your team to make those decisions without you. Although it is good job security if they are really relying on you for that Handshake stewardship. So I'm glad that you shared your experience. Another question about azithromycin overuse. We need it, but it's not always a must. Yeah, so that's one of those local issues that as a team you would want to work on to identify opportunities to improve use. Can you tailor your guideline to lead people to do the right thing for the patients at your facility based on your local epidemiology or your local resistance rates, to identify those patient populations where certain agents are most needed? It also, can you de-escalate? Can you use results of diagnostic tests, if you have access to them, to encourage people to discontinue therapies? That's one of the features of those clinical guidelines, is having a directed therapy section so that people understand, once those cultural results are back, if they have them, or once that patient is clinically improving, what are the next steps for narrowing therapy, discontinuing therapy? That's a really great question that you should discuss at your local level to identify what is the driver of that use and how can you improve it. Another question here, is it mandatory to de-escalate antibiotics based on the culture resort, or purely the physician's decision to continue based on the patient? And I think this is such a great question. It really gets back to that prescriber's autonomy, which is one of the barriers sometimes that we encounter as stewards, is that physician who is right there with that patient, taking care of that patient. I think the best thing that we can do is provide education now during World Antimicrobial Resistance Awareness Week and throughout the year about the importance of appropriate antibiotic use and how de-escalating therapy can prevent that patient, really putting it into the language of that patient, prevent that patient from experiencing an adverse effect from being on too broad of therapy. Really, it's that conversation, and something I think that Handshake stewardship could be really helpful in building those relationships and developing that rapport to enable you to have these more difficult conversations with your prescribers about appropriate antibiotic use. Great question. How to manage patient adherence to antibiotics. Right. So that's another one of those human factors. People feel better and don't complete their course of therapy. I think, again, using patient education resources available from some of our great tools and resources here. The CDC also has some patient education resources about finishing antibiotics. I think if you explore the websites for World Antibiotic Awareness Week, there are also some patient education videos and flyers that you can use. I think that's a really important feature that you can incorporate into your program, particularly if you're in an outpatient setting, is creating flyers that educate patients about the importance of appropriate antibiotic use, not sharing their antibiotics, not saving them for later to, complete that course of therapy. I do also think it's important to make sure that we are prescribing the correct duration of therapy as well, so that we're not giving everyone 10-day courses of antibiotics for things that can be treated with shorter courses. But there's a lot of great opportunities around educating both our providers and our patients. Another question about surgical prophylaxis in a tertiary care center with adherence not going well for them. This is a really challenge that I think a lot of us across the world face. One of the best strategies that I've heard or used myself is really bringing the surgeons to the table to meet with you. They are facing this concern about the development of an infection that complicates their surgery here in the United States. That could lead to financial penalties, certainly makes them worried about those patients that they're taking care of. And so I think bringing them to the table and showing them the evidence, if you have it for your facility, about surgical infections, and if you don't have it for your facility, using our national and international guidelines that might be a conversation about improving surgical prophylaxis. I don't know if I heard this at a conference or read it in a paper, but I know one strategy that was used was, again, bringing these surgeons to the meeting and making small improvements. So maybe antibiotic prophylaxis was continued for 7 days. Okay, can we shorten it to 5 days? And by making these small steps towards improving guideline adherence, you may be able to get your surgeons on board in continuing to move that needle back towards where you want it to be. That's a big challenge that I know a lot of folks are facing. So let me read this question again. I believe this question is looking about comparing individual prescribers, which is a great strategy, benchmarking, and how you should do that because people have different patient volumes. Should we use some kind of coefficient to adjust for patient interactions to show the rate of antibiotic prescribing? And I do think that that is helpful. There's a lot of data out of CHARM program in Michigan where they've done a lot of work, particularly in the outpatient setting, about dashboards for providers. So I'd encourage you to maybe go look at their literature. But yes, I do think you do need to adjust it so that you're comparing apples to apples in looking at similar data between providers. But that's another great strategy. If you have access to data and you have that technology available to be able to create these reports and share them with your providers so they can see where they are compared to their peers in the same practice. Looks like we have answered all of the questions we've received so far. Thank you, everyone, for joining us today on our webinar for World Antimicrobial Awareness Week. We hope everyone has a great rest of this week and good luck on your stewardship efforts.